On. Can you hear me now? Okay, good. Um, Thank you, Dr. Crimshaw. So lovely to meet you. My mom called me this morning from Egypt. My parents go back and forth, and she wanted to give her very warmest regards. And she wanted me to say that before I open my remarks, that it was medical anthropologists that were talking this talk a long time before physicians jumped on the bandwagon. So I apologize for my delay. You know, sometimes when you live in the city, it's actually harder. Whereas if you're coming from out of town, it's easier to be on time. The Rock Creek Parkway was flooded and closed, so it's nice to see some familiar faces. And I'd like to start off by telling you a little bit about my background and the journey that I have taken, so that I can I so that you can understand the context of which from which I am coming from to discuss clinician education. I am a general internist. I've been at GW for almost 30 years now. I began my internship in 1985. Can you hear that? Oh, I'm sorry. Can you in the back hear me? Good. And a graduate of Michigan for both undergrad and medical school. Besides having a very busy practice, my administrative and medical education responsibilities started when I was a clerkship director for medical students as they are beginning their inpatient rotations in internal medicine. And I did that for 5 years. And during those 5 years, you know, when back in the day, the kind of disparaging comments that students would pick up from the residents, like, you know, a Gomer, a patient, get out of my emergency room. There's a lot of sports metaphors. A patient, if you're admitting patients to the hospital, it's a hit and you're up for the next, you're at bat and you're not ready for a hit. And as a clerkship director, I was very dismayed by this kind of objectification of patients. And, you know, I told them that this was really not acceptable, and that, remember, patients are human beings. This is your mother, father, sister, brother. You know, you have to be respectful. And at the beginning of the academic year, which was in July, people really pretty much adhered to that. And then somewhere around the holidays, you know, December, January, all of a sudden they would begin to adopt the terminology, the behaviors of the people that they were working most closely with, which were our internal medicine residents. So try as I might to stop that process, I was not successful. So then I became the program director. I actually just stepped down after 15 years of being program director for an internal medicine residency of 108 residents. And you know, I feel like we have some wonderful faculty, certainly our general internal medicine faculty, internal medicine in general, hospitalists are good people who care about their patients, who want to serve their patients. But again, I noticed that objectification of patients would happen. Now, you may know that George Washington, the hospital, is an urban hospital. The burden of disease can be quite high. When I was doing my training, I would say that the majority of the patients that I took care of at the time, it was a 600-bed hospital, were people dying of AIDS. It was at the height of the AIDS epidemic. The wards now are, in terms of internal medicine, the burden of the disease, which is of course a syndemic, right? The bundling of patients who may have chronic disease, be they HIV, diabetes, end-stage renal disease, along with mental health issues, substance abuse issues, poverty issues, all those things that we, of course, know about the social determinants of health. So what happens is that when patients come in, again, those disparaging comments start to filter through. Um, you know, the frequent flyers, the non-compliant patients, all of that. And again, try as I might, I was not able to halt that process. So I sort of put a mirror up to myself as a program director to say, what, you know, sort of why is this happening? And you put up a mirror and it's like, I have met the enemy and it is me, not as an individual, but as an institution. the way that we train our residents, there is a big problem. And by the way, I'm speaking about residents, but I can include, and I do want to be holistic in my approach. It's our clinicians, and I would also like to include our public health colleagues in this discussion. But certainly physicians, sort of at the top of the hierarchical pyramid, we're probably the most guilty of perpetuating that kind of behavior. So then in examining and really trying to figure out and really shine the light on Washington, D.C., to I established this institute founded in Dorothy Rodham's memory. Mrs. Rodham was my patient. You might know her daughter, Hillary, who's also my patient. Mrs. Rodham came from very difficult means, and education was her salvation. Her sense of social justice was very strong. And so I wanted to establish this institute to shine a light on the dismal situation in terms of health in the nation's capital. I'm sure you're aware, but if you're not, per capita, we're number one in HIV and stage renal disease, cancer mortality. We have the same in pockets of our city, the same HIV rates as Namibia. And when people hear this, they're shocked, and I'm shocked. And I'm shocked that our leaders, political leaders, are not aware of the dichotomy, the paradigm, like many other urban cities, of the division right across from the capital. On the other side of the capital, you're going to see just some striking, shocking scenes. And just to digress a second, when I was taking my niece with me to go to a vigil for a patient's or a colleague's goddaughter had been just graduated from Temple with honors, got killed in a drive-by shooting. My niece, who's exposed to the two cultures, Egyptian American, said to me, "Auntie, this is worse than Egypt." And it's worse than Egypt because the culture of poverty here, I mean, not that poverty anywhere is acceptable, but it's especially cruel here. So, so then in terms of thinking about a model that could really help our learners continue with the the calling of why we all went into the health professions. I think we are all going into this because we want to help, we want to service. This is something that comes from a very deep spiritual place, I would say, for the majority of us. So how can we preserve that bright-eyed, bushy-tailed medical student or nursing student, etc., to preserve that? So the way I believe, and other institutions are doing this and are catching on, is to get people to stay connected with the people that they are serving in the environments that those people come from. So when people are coming to us in the hospital, that's the most vulnerable time, and it's on our turf. It is time that academic institutions take the responsibility of, they talk about corporate responsibility. There needs to be academic responsibility. We need to be accountable to our communities. We need to have a bidirectional bridge so that our communities don't see us as coming and looking for research subjects. There's nothing wrong with research. It's important. It needs to be done. But when everything is always one way, this is a group that is all too familiar with the lack of trust of our communities. So it is serving. So when we had our first summit back in June and we brought interested parties together, from government to FQHCs to high schools to our universities, public health and nursing PA, et cetera, schools, Association of Black Cardiologists, NIH, NIDDK, 100 Black Men, we asked a question. We said, we are interested in creating an action-oriented institute to reduce health disparities in DC. What, in terms of the dialogue, would you have us concentrate on? Unanimously, and it's not easy, especially in DC, to have unanimity on anything. They asked that we focus on two things: education, which made sense, and food. Now, if you reflect on it for any bit of time, of course it makes sense that food is. But for our learners to learn about food, that's, of course, it's catching on, but it was important that our community that we're working with tell us what they feel. And so we have partnered with our colleagues and various NGOs and other groups here in Washington, D.C. And what's happening, and I'll close because I want to really have this as a dialogue, and I also want to introduce other members of the panel that are here, that are part of the group, that are really doing some terrific things. So we just had a 1 week program, which was during the DC Public Schools spring break. It had 45 kids from middle and high schools, Title I schools from east of the river, and now Ward 9, which is Prince George's County. As the gentrification is happening, people are being pushed out. So we included those kids. And we had our facilitators were medical students, undergraduate students, public health students, residents, and faculty. They were the facilitators doing small group sessions where the kids were asked about health disparities. So the group that I was co-leading with an undergraduate student was access to green space. So imagine how powerful it is for a learner or a professional, health professional, to hear from the mouths of babes, there is not a gym in their school, there is not green space. Green space, what a concept. It's asphalt and concrete. So for them, when they began to reflect on that, it's like a light bulb went off. So you mean all the times that I've been wagging my finger at my patients, telling them that they have to exercise and eat their fruits and vegetables, and then the kids tell them, fruits and vegetables? Liquor stores, tobacco stores. So that, if you will, is a way to do applied health disparities education. So I've coined a term, I don't know if it's original, but it's from the classroom to the community. You know how they say from bench to bedside? From classroom to community. In addition, we use the Association of Black Cardiologists heart health curriculum, 12 modules that they created with NHLBI, to have our learners teach applied health literacy education. They were using terms and the kids, when you're dealing with kids, they will call you out. It's a reality check. They're like, no, we don't understand what you're saying. So that model is a model, and I'd be happy to talk with you more about this. We as physicians are new to the game, not just from my medical anthropology colleagues, but from my colleagues who are doing international work and my knowledge of international work. Everything old is new again. People in the international community have been doing community health education for decades. My mother reminded me that 200 years ago in Egypt, actually, or maybe 150, Muhammad Ali actually used doctresses on donkeys as a way of getting health care to rural communities. So I'm anxious to have a dialogue. I could talk for a long time, as you can see. I do want to mention that we have Dr. Lisa Fitzpatrick, who is an NIH-trained infectious disease person. She is a physician who is now practicing at the United Medical Center in Southeast Washington, D.C. And Lisa single-handedly created the HIV red carpet program. So anybody who gets swabbed and is found to have HIV, before they leave, they have an appointment with Dr. Fitzpatrick, with a social worker, with one of the patient navigators, who I hope are here, Marjorie and Davida. So please raise your hands so people can see you. And they also get dental appointment and a mental health appointment. And they'll correct me if I've missed anything, so that, what's that? Of course, primary care. I'm a general internist, of course. I just assume that's included. And so if a patient does not show up to follow up, the patient navigators will go and find out what's going on. If that patient gets admitted, they follow them into the hospital. So it is that kind of experience that we want our learners to have from day one, to see where people come from. And finally, in closing, our Food and Friends colleagues, they run a meal delivery program that started in 1988 for people who have AIDS and now cancer and hospice, have agreed to let our learners go along for the meal delivery programs. Going in somebody's house with any illness, it doesn't take weeks and weeks of clinical experience. One day is enough. So thank you for your attention, and I look forward to talking with you.